I'm Ruby Hawker with the American Lung Association in Minnesota, and welcome to the 2016 Special Considerations in Asthma Webinar Series. Thank you to United Health Foundation for supporting this webinar series, and a special welcome to our United Health Foundation partners in Asthma Action Coalitions joining us across the Upper Midwest. Before we get started, we have a few housekeeping items to cover. All lines are muted. If you have questions during or at the end of the presentation, please use the chat box function in the lower right-hand corner. 2, a copy of the recording of today's webinar will be shared with participants, and feel free to share with your colleagues. And number 3, we invite you to register for July and August webinars. We will include a link to these in a follow-up email to you. Now I would like to welcome Valerie Schend, who will be discussing new asthma medications and how they fit into existing asthma guidelines. Thank you for joining us today, and I'll turn it over to you, Valerie.
All right. Good afternoon, everyone. We have kind of a cloudy, ugly day here in Madison, but I guess the heat is abated for a bit. So anyway, so we're going to talk about recently released medications and the GINA guidelines and how we're going to take care of our patients with asthma. Just to let you know, I actually am a certified asthma educator. I always forget to put that credential on. That is important to anyone. I have no financial disclosures, and today we will be discussing off-label use of some medications, just so you're aware of that. I thought it would be fun to kind of go back and look and see how medications have been used in the treatment of respiratory diseases and kind of when they started. So the earliest we can see is back in 2600 BC, the inhalation of Ma Wang, which actually is still used in some herbal preparations nowadays. Ma Wang is a species of ephedra, so that stimulant is still used. And then they talk about black henbane and rosins and herbs boiled with vinegar and oil, stramonium and hemp, arsenic, hydrocyanic acid. A lot of these medications, as you look through the list, all have anticholinergic type properties, which are a lot of what the newer medications are. So even back in the days they were using these. I would not have been one of the people who would have wanted injections of these things directly into my trachea, but I think in those days they used whatever they could to help. But so they were using the kind of medications in a cruder form that we're using nowadays today. And they started using inhalation therapy back then to directly deliver the medication to the airways, which is our preferred route now, to decrease the systemic availability. However, as we all know from working with our patients, coordination and use of the type of inhaler can be difficult. We get a lot of deposition of the drug into the throat and back of the throat rather than directly into the lungs. There can be dose-to-dose variability, and it's what is the correct dose for which patient has always been something we've worked really diligently to try and help our patients with as well. I mean, in pharmacy we're taught you want to use the lowest dose possible to achieve the best response with the fewest number of side effects, and I think that's what we all do in caring for our patients. So we had the Globe multi-nebulizer, and I think I would have been really intimidated by trying to use that. Then we have this Newton's inhaler where you just put your product in and twist the crank and try breathing in that. And then the pneumostat. So all of these are kind of early inventions of inhalers. So the first guidelines we're looking at, the NAEPP, was in 2007. And as you can see, Nadocromil is no longer available, so that's one thing that's changed over the years. So we don't have that. Then there was the Asthma Quick Care reference that came out in September of 2012 that kind of looked at preferred treatments and that type of thing. And in this amount of time, we kind of had changes in the philosophy of the guidelines about thinking about impairment and risk rather than just symptom-based treatment and that type of thing, looking at the whole patient. And we had newer drugs. We had LABAs and different strengths and different products. So we had different ways to go with treating our patients. And we had the advent of the biologics as well to help our patients. So we had a lot more options in 2012 than we did in 2007. And then more recently, we had the GINA guidelines come out in 2015, and they're a little bit more radical. For step 1, that's your intermittent asthmatics, but their step 1 was really limited to patients who only had symptoms less than twice a month. So anybody having symptoms more than twice a month was a candidate for controller therapy. So we had the low-dose ICS in step 2, low-dose ICS plus a LABA in step 3, and then in step 4, they increased the LABA to a medium or high-dose ICS with a LABA, but alternate treatments were adding tiotropium and possibly or high-dose ICS and LTRA. So this is the first time we're kind of seeing an anticholinergic as a controller treatment in the guidelines. Previously in NAEPP, we had ipratropium just for more severe exacerbations. But when you look at the package insert for ipratropium, there is no FDA approval for using ipratropium in the treatment of asthma. And we've used anticholinergics all along for some of our patients with asthma. So that's kind of where we're starting to get into the newer options. And for step 5, they only have 5 steps instead of 6 as in the NAEPP. That's where they're referring to the add-on treatment with the anti-IgE. So, and now we also have newer biologics that I'll discuss later as well. So we have more medications in our arsenal to help treat our patients. So as you can see, the differences between, the differences between GINA and the EPR is when they're a little bit more liberal, starting higher dose ICS in step 4, and they've got using tiotropium, adding the anticholinergics. I'm assuming with the next iteration of the EPR guidelines, we'll see more use of anticholinergics, although there's not a whole lot of published studies out right now looking at anticholinergics. There is a lot of work going on with people looking at anticholinergics, how we can add them to our arsenal and what to use. So right now, this is what we have, and so those are kind of the differences between GINA and EPR in step 4. And when we look at step 5, GINA doesn't think of using a specialist till patients are at step 5. EPR will start looking in step 4 with our more severe patients. And once again, we have omalizumab and tiotropium, which is going to be different than we have in EPR. So, and they're considering adding oral corticosteroids in both groups and considering omalizumab. So quick relief medications, in GINA we have PRN, SABA, and when you get into some of steps 3, 4, and 5, they're talking about low-dose ICS and formoterol. Initially it was just budesonide, but now it's both budesonide and beclomethasone. However, that's only a quick relief medication for patients who are already using the combination of budesonide or beclomethasone as formoterol. You would not prescribe this as quick relief medication for somebody who's not already using it. And I'll kind of go into some of the studies where this information came from. In EPR, it's just a short-acting beta agonist is needed for symptoms. Short-course oral corticosteroids can be considered. And once again, in more severe exacerbations, we can add ipratropium. And as you know, in caring for your patients, we do have some patients that are better responders to anticholinergics as opposed to beta agonists. So you'll know who those patients are and consider using the anticholinergics. But one thing to remember with adding the anticholinergics is generally They have a longer onset of action for our patients, especially when we're talking the ipratropium as opposed to albuterol or levalbuterol. So it'll take longer for them to exert their effect. And so there may possibly be some issues for patients who need a quicker onset of action, so a beta agonist would be their preferred drug. But you might consider an anticholinergic if, especially when we're talking long-acting, if we have a class of patients who are not candidates for long-acting. Some of our cardiac patients don't do well with long-acting beta agonists. There can be the increased risk of adverse effects with the long-acting beta agonist. Some of those can be more prominent in LABAs as opposed to LAMAs. And in some patients, the LABAs just are not effective, so then those would be the patients we would think about adding the tiotropium or possibly a different long-acting anticholinergic or antimuscarinic agent. And we'll go over all the medications, so. So then we have the newly released GINA guidelines, Global Initiative for Asthma. So they kind of went to a management cycle, so review response, so you always want to kind of look at what's going on with your patient, how are they responding to therapy. When you're assessing, you want to always look at their overall asthma control, adherence, technique, what their preferences are and what their risk factors are. And then after 2 to 3 months of treatment, adjust treatment if you need more or less if you're not getting the response you need. And the assessment is really important, especially when we're looking at technique, because as we'll go into later, there are a lot of different types of inhalers, so patients can be using 2 or 3 different types of techniques to get the medications they need into their airways. So technique is becoming more and more important because we want to make sure that the inhalation is adequate to get the medication into the airways. So once again, we kind of have the stepwise approach to control symptoms and reduce risk. So as I said earlier, step 1 is when symptoms are going to be less than twice a month. So those are going to be the patients who are just on a short-acting beta agonist just for as-needed symptom control. Step 2, they went into a little bit more detail with preschoolers, and because it's really difficult, as you know, to come up with a diagnosis of asthma in these times, so in this age group. So pretty much the thought is that we're going to do a trial of a low-dose ICS and see how the kids do. We'll do a therapeutic trial and then kind of discuss medication choice with the parent based on ease of use. Do we want to use a nebulizer? Do we want to use an MDI in a face mask? What's the best way to get the medication into the airways? And then, of course, as we know, always formulary concerns. And then, give that a trial for 2 to 3 months, see how the child's doing. If we stop the medication, does condition deteriorate, or do they stay the same, or are they a lot better, and so are we going to keep them on the medication? Alternatives could be a leukotriene medication, but unfortunately they're easy, but usually improvement is less consistent, so we have to be a little bit more on our game monitoring these kids, and we may not want to wait 2 to 3 months to see how they do if we try a leukotriene modifier, so we might want to check with them more quickly. And then there has been some work looking at episodic high-dose inhaled corticosteroids for that age group, but that one we have to have a pretty savvy patient population, so we have parents that are right on their game so they know exactly when to start it and when to stop it, so we don't have overuse or underuse and therefore not treat the child appropriately. So we still have the stepwise, depending on, in the guidelines, it kind of tells you based on symptoms which step you might want to consider and what type of medication to use. So you're always going to provide guided education for each step and each therapy that you're using. You want to know what the risk factors are for that particular patient and consider stepping up and or stepping down if symptoms are controlled or uncontrolled, if they're at higher risk due to time of year, allergies, occupation, that type of thing. So there's always a lot of information we have to put into our decisions as to when to step up and when to step down in treatment. Definitely in adults, generally they are not going to be patients that generally go off ICS. They're going to need to stay on at least a low dose. Children, we're going to have a lot more flexibility. So now I'm going to kind of talk about the SMART study, and this is how they determined the fixed dose budesonide formoterol and using budesonide and or beclomethasone now, PRN, during exacerbations. So these patients were randomized to either budesonide and formoterol scheduled and as needed, scheduled then with PRN short-acting beta agonist, or budesonide and PRN short-acting beta agonist, with a maximum of whatever their blinded study medication was to 10 inhalations per day. So they found that by doing this, the patients using the PRN budesonide formoterol did have a prolonged time to first severe exacerbation and a reduced number of exacerbations requiring oral corticosteroids, decreased use of reliever medications. However, there was no change in number of asthma control days or no change in quality of life. So it did help with the exacerbation part, but not overall status of your asthma patient. So they may have had fewer exacerbations requiring oral corticosteroids, but so the information, the studies are kind of okay, but you have to, like I said, you have to have a pretty savvy patient to use this. And then in the Cochrane reviews, they looked at intermittent inhaled corticosteroid versus placebo for persistent asthma. And this was in children, so they used preschool-age children, school-age children, and adults. So there was some overall reduction in asthma exacerbations requiring corticosteroids and improvement in daytime and nighttime symptom scores. However, no reduction in hospitalizations, and parents were noticing and perceived increased quality of life. So there is some information for this, that this might be an okay therapy, but once again, we have to be careful that there's not overuse or underuse of inhaled corticosteroids in this patient population. So once again, you have to have a very savvy and aware patient to know exactly when to start it, how to use it, how long to be on it. So, and then in the GINA guidelines now, they develop a whole chapter to ACOS, or the Asthma COPD Overlap Syndrome. So this is something that's been getting a lot of coverage, media attention lately. So these are patients that are going to have both symptoms of asthma and COPD. The asthma is going to be partially reversible, the FEV1 and that type of thing, but there's also going to be some parts that are COPD-like that it's going to be a progressive airflow limitation. So generally, when you're looking at your older patients who have COPD or obstructive lung disease, 15 to 20% of those may have some reversibility, leading to more of a definition of the ACOS or the asthma COPD. So generally, COPD is going to be in the elderly anyway, but you're going to see this more in the African American populations and those with greater disease severity, both asthma severity and COPD severity. So kind of looking at the comparison of asthma and COPD, age of onset for asthma is often in childhood. COPD is generally when you're older and over 40 years of age, and probably even older than that. Symptoms are going to be more intermittent and trigger-driven often in asthma, whereas it's going to be persistent with probably daily symptoms of fluctuating severity. So there's always going to be some underlying type of symptoms but how bad they are can differ from day to day, and there's going to be that chronic cough and sputum production in patients with COPD. Lung function is going to be variable in our patients with asthma. So one day they can be in and their FEV will be, 95% predicted. The next time they come in, it can be 70. Generally, it's going to be persistent in COPD, and it's going to be decreasing as time goes on. So in asthma, obviously there's a previous diagnosis of asthma or a family history of asthma or atopy. COPD still can be referred to as emphysema or chronic bronchitis, so patients will come in talking about that. And obviously the heavy exposure to risk factors, either tobacco smokers or occupational, where they're exposed to a lot of fumes, or in an area with lots of particulate matter in the air. The time course for asthma, there's no particular time course. It's not progressively worsening and variation in the symptoms. Even without treatment, sometimes, although rarely, patients may improve with an asthma exacerbation. One puff or a couple of puffs of their short-acting beta agonist and they're better, and they will respond to ICS over time. Once again, it's slow but progressive worsening of symptoms, limited relief with their rescue medications, and the response to inhaled corticosteroids can be variable. Although our patients with the ACOS or the overlap syndrome, because there is that component of asthma, they will respond better to inhaled corticosteroids. And then chest x-rays, generally in asthma, they look normal, and you may see that severe hyperinflation in patients with COPD. So once again, you're going to have the increased and progressive symptoms, more frequent exacerbations, different inflammatory patterns. So in COPD, often it can be neutrophilic inflammation. In the ACOS patients, you're probably going to see more of an eosinophilic inflammation as we do in asthma. These patients will respond better to inhaled corticosteroids because of that asthma type phenotype along with their COPD. Decreased quality of life, especially reduced physical activity, and these patients are going to be at an increased risk for increased morbidity and mortality. So these patients are sicker and probably not going to do as well as a patient with just COPD or just asthma. So now hopefully we're all familiar with the different ways of assessing and classifying COPD. So this is the assessment score, so we'll have groups A, B, C, or C or D, and that's definitely based on their score, the GOLD guidelines for COPD, and their CAT score or their MMRC, which here is the GOLD classifications looking at lung functions, and generally symptoms too, how patients are feeling and that type of thing. Unfortunately, most of the patients in the GOLD 1 category are pretty unaware that they even have any breathing difficulties, but mass screening to try and find out if anybody might be in this classification is not recommended because anybody could be here at any point of time, whether they have COPD or not. So mass screenings for COPD are not recommended. Generally here in the GOLD 2 with the moderate disease are when patients are going to start realizing they have some kind of issues. They have more shortness of breath and more problems with their daily activities of living. So they're going to be the ones who are going to be coming in more at risk with their lifestyles. And the MMRC is, you can kind of grade based on what their symptoms are, how they feel as they're walking, going about normal daily activities, walking into the house, getting dressed, that type of thing, walking to and from the car, walking from the car to the grocery store. The COPD assessment test is similar to the ACT or the CACT that we use for asthma. So it's graded, and they can determine how they're doing. And as with ACT, the score definitely kind of tells you where they are with their overall symptoms. So these are all good tools to kind of try and figure out where your patient is, especially if you think there's that overlap and there's decreased quality of life and more symptoms kind of leading you towards that COPD definite assessment as opposed to just asthma. So when we look at the pharmacologic management of COPD, and just so SAMA is short-acting muscarinic agent. Some places you will see SAAC or LAAC for anticholinergic. So SAMA and SAC are interchangeable, as are LAMA and LAC. I just like saying LAMA better than LAC, so that's one I always use. So for your less ill patients, generally they're on the short-acting agents. However, if they're starting to progress, you might think about long-acting therapy or they're using this on a regular basis. You might want to think about more long-acting therapy with the LAMA or LABA. As opposed to asthma, and you will see that you can use the LAMA without any other type of controller medication, but these are strictly for patients with COPD. If you think it could be that COPD asthma overlap, that is definitely an indication that that patient should be on an inhaled steroid and not just on a bronchodilator. So as I indicated before, we have a lot of different kinds of devices. We have the traditional pressurized meter dose inhaler. So we have the HFA, the Aerospan, the Aerosphere, and we can get our rescue medicines, our long-term control medicines, all in an MDI. The dry powder inhalers, we have the Discus, Ellipta, Flexhaler, Twishaler, Handhaler, Neohaler, and the Aerolyzer, although I've kind of heard this is on its way out. Formoterol as a single entity may not be available much longer, so that will be something that we would be taking off of this list. But here we start, when we talk about dry powders, we're decreasing the number of medications that are available, the types of medications that are available. Then we have the soft mist inhaler, the Respimat, and once again, those are only, we have the Sabasama that might be useful for some of our patients with asthma that aren't good responders or that have more severe acute exacerbations. They may do better with the Sabasama for rescue, but otherwise it's pretty long-acting controller medications. Then we have the breath-actuated inhalers, the Respiclick and the Pressair, which is a short-acting rescue medicine, a long-acting controller medication. And then we have nebulized medication, which kind of go across a lot of the indications for asthma. We have short-acting, both antimuscarinics or muscarinic agents, beta agonists, combinations, long-acting beta agonists, and inhaled corticosteroids that are all available in a neb form. So for our patients that can't handle any of our automatic devices, we can still treat them well with nebulized. So now when we're looking at the quick relief short-acting medications, we have the short-acting beta agonist, albuterol, which is available as an HFA, a DPI, and a neb solution. Levalbuterol is the traditional MDI or a neb solution. The short-acting muscarinic agent or anticholinergic would be ipratropium, available as Atrovent or the neb solution. And then we have the combination of the short-acting beta agonist and muscarinic agent in the Combivent, Respimat, or Duoneb for the nebulizer. So we can take care of our patients short-acting for an exacerbation in a lot of different ways. So between all these different inhalers, we should be able to find one that works well for our patients. And we can use, the HFA and even infants, if we use the face mask, the AeroChamber, or whatever your chamber of choice is with the face mask, that can work well for most patients. Or even elderly patients that have a hard time with the coordination of doing their inhaler. Long-acting controller medications, obviously the cornerstone of asthma treatment are the inhaled corticosteroids. So when we kind of look at those, most of them as just a corticosteroid, not a combinations product, these are just indicated for the maintenance treatment of asthma. So you won't see any of these as just an inhaled corticosteroid indicated for the treatment of COPD as a standalone medication. Because in COPD, there can be an increase, especially with fluticasone, there can be an increased incidence of pneumonias in some patients with COPDs. So that's why we're going to be a little bit more careful with ICS in our COPD patients. So all of these, we do have FDA approval to use in the treatment of asthma. But once again, a lot of different types of inhalers, so a lot of educational opportunities. So if a patient isn't getting better and they have 2 or 3 different inhalers with 2 or 3 different techniques, that's going to be something that's really important for us to go over in the offices to look and see what's going on. So, and the long-acting beta agonists, we have, you'll see differences here where as a standalone product, you're going to see them only for COPD or in asthma as concomitant therapy along with an ICS or some other kind of controller medication. However, salmeterol and I think formoterol are also indicated for the occasional treatment of exercise-induced bronchospasm. So it wouldn't be anything patients would be on as a daily therapy for their exercise-induced bronchospasms. But for patients who are going to be doing all-day events, they are indicated if they need 12 hours of coverage of a bronchodilator. So, and then we're kind of looking if 2 or more as-needed controller medications are needed. So we've kind of talked about when we're going to step up. So if you need to step up, you can use the same dose of ICS, but then add a LABA, or even go up to a higher dose ICS with a LABA if you want to kind of do 2 steps forward. So you're going to need to kind of watch the guidelines and know when to treat, but the as-needed low-dose ICS and formoterol is something that's in GINA guidelines, but obviously not approved here. Once again, you have to have a very savvy patient before you would consider using this. And I will admit, after I looked at this, after I had sent it off, I forgot to add the Bevespi Aerosphere, which is glycopyrrolate and formoterol. So that's a combination of a LAMA and a LABA. So that's one of the products that's available too. So we have the long-acting muscarinic agents, the aclidinium glycopyrrolate, tiotropium. Now with Spiriva, we have to be careful because the 1.2 micrograms per actuation with 2 inhalations once a day, that's the one that's FDA approved for asthma. The 2.5 microgram per actuation, 2 puffs daily is the COPD dose. A lot of that is going to be driven, obviously you would start with the 1.25 microgram one for your patients with asthma, but it's going to be based on how your patient does and formulary concerns. The hand inhaler has been looked at in asthma too and has been shown to be helpful in some patients with asthma as opposed to non-inferior to salmeterol. So depending on your patient, and once again how we talked about patient preferences, side effects, that type of thing. So tiotropium is available as the 1.25, 2.5, or the 18 microgram hand inhaler. So we have all those options for tiotropium for our patients. And once again, different indications for the different strengths. Umeclidinium is another newcomer to the group, and once again for COPD. Although, as I said, a lot of these are being studied in asthma as well, so we'll probably see new indications on the package inserts within a year or two. I'm assuming for some of these to be used as controller therapy for asthma as well. Then we have the combination of the ICS-LABA, and as you see, the 250-50 dose of the Advair is indicated for COPD. None of these are going to be the high dose inhaled corticosteroids when you see for COPD, and also with our patients with ACOS because of as I said earlier about the risk of pneumonias in our patients with COPD. So we want to be careful how much ICS we give those patients, but they are indicated for both asthma and COPD. And then we have the LABA-LAMA. Oh, I did have the Bevespi here. I apologize. The umeclidinium and vilanterol, the indacterol and glycopyrrolate, and tiotropium and aldaterol. So all of these are different types of inhalers, different techniques. So depending if you're adding this to an ICS, you're going to want to look and see what ICS you're using, what type of technique, how to teach your patient how to work with them so they're getting the best use out of all their medications and the most of the medication into the airways. Biologics, we've had omalizumab for a while. Recently approved were both Nucala and Syncare. Mepolizumab and reslizumab are both anti-IL-5s. Mepolizumab is a sub-Q injection every 4 weeks. Reslizumab is going to be in-clinic IV infusion. So a lot of these are going to be driven by formulary concerns as opposed to what you want to use. Mepolizumab, we're kind of thinking that we might see mepolizumab used in the home because there's no black box warning. So we may see it like we see some of the other biologics in rheumatoid arthritis and the rest of them, that patients may be able to use this as an at-home therapy. So there will be a lot of formulary considerations, prior authorizations, and all that we're going to have to do. So we're increasing our options of treating our very severe asthmatics with more biologics, so that'll be helpful for them, keeping them home, out of the hospital, having those severe exacerbations. And then we also have another newer therapy, bronchial thermoplasty for the severe persistent asthmatics. It is an add-on treatment in step 5 of the GINA guidelines. We haven't gotten there yet in the NAEPP guidelines. This does work in the select patient population. They kind of go in with a probe, a heated probe, and thermal energy is directed to the airways, and patients will have to go in 3 or 4 times because they target different areas of the lungs each treatment, so it's not a one-time fix. Patients will go in often. But patients who have had the therapy have been very happy with it. However, because it is a more in-depth procedure, there can be some pretty severe adverse effects. So once again, you need to be careful with that, but it is an option for our severe persistent asthmatics. And then just this is kind of for your own edification, I have put together a table kind of looking at low, medium, high, and high dose with all the different inhaled corticosteroids via whichever type of, whether it's an HFA, dry powder inhaler, neb solution, that type of thing. So you kind of can have an equivalent idea of what to do with dosing based on formularies, based on step-up therapy, and that type of thing. So that's what I have for you today. And Rhonda, I don't know about if slides will be available. That's a question for Ruby.
We can email those out to those that would like them. That would be pretty easy for us to do. And this is some really great information. So I definitely understand wanting to have them on hand. Now, if you have any questions about the presentation, you can start entering them into the chat box.
Elaborate on the use of asthma educators. Yes, I think we're an important part of the healthcare team. I also work part-time in one of the managed care clinics here, and we're expanding our use of asthma educators and setting up separate appointments so our asthma patients can come in and see us. We have a respiratory therapist, and obviously as a pharmacist I'm kind of biased. We have some of our pharmacists serving as that point too. Because we're a closed healthcare system ourselves, reimbursement isn't anything we need to worry about right now. We don't have to send it on to another healthcare organization to get reimbursed. It's just within our own organization. But I think it's an important thing we can do, and obviously when I'm practicing as a pharmacist and dispensing medications, I try, and if I have a patient who's overusing or underusing, I'll discuss with them there and then send a note to their provider as well so we're all on the same page. But I think that we are an important part of the healthcare team, and we have to figure out more options and more ways to get us involved in the care of our patients. And I don't have the answer.
All right. Any last questions?
You're welcome.
All right. Well, thank you, Valerie. That was really great. And thank you, everyone, for attending. Again, this is just one in a series of a monthly Special Considerations in Asthma webinar series. In July, we will be joined by Lila Kurtz, and she'll be presenting on severe asthma in the pediatric patient. And then in August, we will have Marcy Ballman joining us to discuss improving air quality in wood stove homes. So we invite you to register for these webinars. And again, a recording of this webinar will be sent to participants, and you are welcome to share. And I just want to say thank you to everyone, and thank you very much, Valerie. This was great information.
Thank you, everyone. Yep. Bye.